This is your
chance.
Huh?
This is your chance to
That's
ask
right.
us.
We're up here on the hot seat with the hot lights, and again, we want this to be very interactive. I think this is we have 75 minutes, and we want to try to limit it obviously to questions, but I think we'd be willing to be a little bit more liberal on the discussion as opposed to just questions. Maybe some editorializing from the crowd, since we're not. We always want to be careful that we're not monopolizing or eating up a speaker's time, but we wanted this to be very relaxed and casual. So do we have any questions or comments or anything about the convention? Now we haven't done it yet, but I think now that we're kind of in the end, we're in the home stretch here. We picked those mics, the foam box mics, because they're intended to be tossed to the next person. That way Kira's not having to run all over the room. So if anybody is up for a little catch, enjoy it.
So I understand that with DPC, for certain positions, it works very, very well. I happen to be a pediatrician. So, most people know that in pediatrics, people will pay more for their dog than their child. And we also have the high cost of vaccinations. So most of us that are pediatricians do kind of like a hybrid model. We have to, in order to remain solvent. Is there a, not really a go-to, but do you guys have any brilliant out-of-the-box ideas that maybe pediatricians could take more advantage of the DPC side?
Throw that mic to Lee Gross or Adam Wheeler or Kendrick Johnson. Oh, Lee Gross is right next to you.
Oh, there you go.
Sorry,
it's more
the
of a handoff.
Sorry, the lights are bright, Lee.
Yeah, I mean, we talked about this at length last night. I think she was really trying to get your ideas to, you guys have a lot more national context in this, and to see if you had heard of any sort of developing issues. There are some, we talked about some legislative and regulatory areas where, if a pediatric patient, like a pediatric Medicaid patient, is seeing an opted out doctor, the pediatric patient can no longer get Medicaid vaccines. And so there are some regulatory issues and legal issues surrounding that. And so can you, work in Washington to allow, opted out physicians to still treat Medicaid patients and allow them to access Medicaid vaccines? And there's some important things along those lines. You educated me on some areas where, the commercial carriers are still paying for the vaccines, even if the person administering the vaccines are opted out, which is great, but then you still have to submit claims to them, which means you're having to have a compliant EMR that allows you to submit those claims, which greatly limits your options. So if there's somebody that's built the perfect pediatric mousetrap, I know there are lots of people working on it, and I'm not sure anybody's nailed it just yet. But if somebody knows of one, I'm happy to entertain it.
Well done. That's how it's supposed to do, right there.
Oh my gosh, that was nerve-wracking. So, I'm the spokesperson for the Carolinas chapter, and I guarantee you, if he were still with us today, Dr. Brian Hill, who had Gold Standard Pediatrics in Anderson, South Carolina, would be in one of these seats. And, oh my God, I'm not gonna cry. But he died. And he was a good supporter of this organization, and he was a leader in the pediatric space in direct primary care, and he had a thriving practice. So I would encourage you to call Dr. Shane Purcell, who was his colleague, and they shared space. So Dr. Purcell's very thriving DPC practice that has, I think now, 4 doctors and a nurse practitioner, was upstairs, and Gold Standard Pediatrics was downstairs, and he was just awesome.
Yeah, and I would encourage you to listen very carefully to the question you ask and look at that question through the appropriate lens, which is, how do I secure how do I secure permission from the Almighty One who supposedly cares so much about all of us, including the little children, to be able to make treatments available to them without bankrupting them. And so your question is a great one, but I mean, the way I hear that also is, how do we get the government to not participate in the destruction of the care that people need? And that's the role. They just need to get out of the way.
I don't really have a question. I'm Molly Rutherford. I own a direct primary care practice in Kentucky. And so I was just going to add on to what you just said and tell a little bit of the story that I've been fighting for. I've been fighting the Medicaid people in Kentucky, or meeting with them.
What's the difference?
For 7 years. And through 2 administrations, we had a governor who supposedly was on board, but what I learned was, and if anybody has any advice on how to cut through this, the bureaucrats are the same through each administration. So it's very difficult to explain to them, we're trying to help you. Like we will save you money. Allow these Medicaid patients to pay us directly, because in Kentucky, I think we're one of 2 states that has a law actually that if I have a Medicaid number, like if I'm enrolled in Medicaid as a physician, then I'm not allowed to charge Medicaid patients directly. So my only choice is to not participate. And then if I have some patients who have Medicaid, they choose to see me anyway. And then luckily, usually they can get their medicines from that I dispense. So it's not a problem usually. But if they need a referral for something, my referral is not going to be honored. And then for my patients who take buprenorphine, for example, which is kind of an expensive medication, Medicaid is not going to pay for that prescription for them. And, like I said, it's
a slippery slope.
It's very difficult to break through the control that they want. In the meetings that I've had, they're worried about physicians taking advantage of the patients. And so I always try to tell them that's actually happening at the FQHCs, that's happening more in the system than it is among direct primary care doctors. And that's another thing they don't get. They think that we become direct primary care doctors to make money. And I have to remind them, no, I can make a lot more money in the system. Like that's not why I do this. So yeah, if there's anybody policy-wise that maybe can reach out to those of us who are trying to remove those blocks, that'd be great.
We had a contract with the state of Oklahoma at Surgery Center of Oklahoma that would have saved the state $200 million, and they destroyed it intentionally. They sullied that. They came back to me and told, we need a 40% haircut off your website fees in order to keep working with you. So we fired them. And I fault myself for not recognizing early on that we were dealing with an unwilling buyer. I mean, my God, that's one of our pillars. And it didn't dawn on me until way into the process. I was dealing with an unwilling buyer, and that's probably who you're talking to. And the idea that you're going to take advantage of the Medicaid patients, we were recently approached by a federally qualified health clinic. I think that's what they're called. And they have 120 children who are on a waiting list, almost all of whom are Medicaid, for dental restoration. So pediatric dentistry case, little kids, teeth are all rotten. And none of the so-called not-for-profit hospitals that have been taking care of them will give the surgeons any OR time anymore because they can't figure out how to make any money on these cases. So they have a waiting list. We're approached, Lee, I thought of you because you have your story about being able to save them money. But they came to us, and Steve Lantier met with them and showed them our all-in bundled website price, and they thought it was the anesthesia charge based on what they'd been exposed to. So we're probably going to have these patients pay us directly, or some generous benefactor is going to step up. And my question was, well, do you want to do all those cases tomorrow? Or you want to do them all next week? I mean, we start at 5 a.m. and go until, the dentists can't work anymore. But we could knock that out in no time. They also had patients that are in line to get a hysterectomy. I mean, it's just so dysfunctional. The government has no business in this industry at all.
I might give a little input on that as the non-physician on the stage here. Trying to get the law changed and get government to be easier to deal with, I think we could all be dead by the time that ever happens. Trying to source those vaccines, I'd almost look to see if there was some sort of a foundation that might be willing to assist, or maybe multiple DPC practices around the nation. If you could pool your resources and maybe leverage some contacts and see whether or not there would be some sort of a foundation for this particular type of scenario, again, for the DPCs to remain independent. We talk about this at my shop a lot, because we're always, how do we operationalize this? How do we build a process around it? And I always, I look at DPC as please don't let anybody take this wrong, but I look at it as a very magical and somewhat fragile thing that, if you all lose your principles and say, well, we're going to be DPC and we want to be independent, but we want to do a little bit with government over here, or we want to adapt ourselves so we the carriers will be friendlier to us. I think the DPCs have got to be very careful not to kill the golden goose and lose the magic that you all represent.
I don't know if David Ballott's still here. I know Jonathan Small had to drop back. The light's bright, David, so if you're here, I can't see you. The State Policy Network, if you want to continue to pursue that, is the outfit that has basically conservative think tanks in every state. Kentucky has one too, I believe. And that's probably where I would go. And then let them kind of be the intermediary and slog through that cesspool for you. You have better things to do, Molly.
There's a couple of online questions. Question for Keith. Do you provide a consultation service for my local surgical anesthesia colleagues to consider? We need your model in Fort Myers because there's a major hospital monopoly / dynamics here.
The first part of the question is, do we what?
Provide consultation services.
Like for me to be a consultant? Yeah. They just need to be here. Yeah, I mean, they can email me and my response is always the same. When someone wants to pick my brain, I tell them to, join FMMA so I know you're serious. And then if they join, then Jay and I are an open book. I mean, we'll help anybody. Is Eric Inman here? How many emails have we exchanged? Yeah. Yeah, they're opening up a surgery center in Indiana, and just Steve Latte and I are nostalgic. Sorry, guys, they're going through the worst time, but it's nostalgic for us because it reminds us of what we went through. Yeah, so I'm happy to help. And I suppose if my involvement needed to be terribly involved, then, we could have a conversation. But in all likelihood, the local hospital could be turned into a provider of transparent services using the Atlas medical billing tool. That's one thing, but I'd be happy to talk to them after they join.
Okay.
Obviously, they're members because they're on the online, but happy to talk to them.
One more, and then I'm going to throw the mic. How do you best educate the public on direct pay as an option? They don't understand there are options outside of insurance. Is this through an aggressive public marketing campaign or by directly calling on referring physicians?
I would say social media. Surgery Center of Oklahoma is very active on social media. And if we're talking about individuals, self-pay individuals, then I think Surgery Center of Oklahoma and most of the other successful free market facilities are pretty active. Again, social media, word of mouth. Usually they have great websites. If we're talking about self-pay or direct pay on the employer side, You know, it's conventions like this. We do a fair amount of outreach through, you know, the different benefits associations, things of that nature.
Yeah, and I think, you know, the cost shares too that are here, they're in a way for Surgery Center of Oklahoma to promote self-pay could be misconstrued as being self-serving. But I think when the cost shares do it and on the buyer side, the promotion happens, that's when I think we'd really hit that tipping point. I think on those who are providing services, if they're promoting direct pay, then there's a few questions you have to ask and then before they trust you.
I think there's another, you know, direct primary care is a great promoter of the direct pay and cash pay facilities. Because most, I mean, if you want to know where, you know, the Surgery Center of Oklahoma is in your state, ask a DPC.
Mm-hmm.
I had a question. There's been a lot of great information shared by a lot of folks this week, and in ways the FMMA and this movement moves forward. I think we also probably are all aware that the evil cartel giant is probably not sitting idle and not only going to be playing defense. So what type of thing, if there is such a thing, what things do you guys both think about that might keep you up at night? Is what is the attack that might be coming? Is there something we should be aware of to get out in front of it, whether local politically, legislatively, just circling the wagons with our local providers or what have you, as this movement goes forward?
My opinion on that is it's a little bit, it's not what you would think. I've had for 10 years say, oh, are you concerned about the hospitals getting into this game and you know, offering cash bundles? No, definitely not. That's an area that they just can't survive in. They're too inefficient. Why would they try to lower their prices? So that's not the concern, but you know, the carriers are doing, honestly, you know, most of the carriers, the weapon that we see more often is, I hate to say it, but it's through the consultants and the brokers. You know, the fear, doubt, and uncertainty, which is the hallmark of a bought and paid for consultant that works for the BUCA. That's probably the biggest thing. If you attended the legislative session, you know, David and Jonathan mentioned, you know, certain transparency bills or certain bills that would make DPC or free market medicine more, make it easier in a particular state. Yeah, the hospitals and the carriers, they come out of the woodwork and kill that at the local legislature. So those are, for me, the two primary weapons that I see that are continuously, it's just always out there.
Yeah, I don't know that I have anything to add. It's you know, it's the red pill theme, because the obvious path, I think, is the one we're describing. I mean, it's hard to argue with cheaper and better, and anybody that has an issue with what we've recommended has a problem with cheaper and better, and there's a reason for that. And so, you know, we have to focus on ourselves and our ability to communicate and make ourselves better, and not denigrate the other side too much, as fun as it is at times. But we just have to improve ourselves and make sure we can communicate the message well and shine a light on things and just be honest and enter into mutually beneficial exchanges. And those who want to throw rocks really look awful if we present the message as well as every speaker who's been here this weekend has presented it.
Yeah, I want to emphasize it again that, you know, if we get to a point where the hospitals start posting their all in, all done bundled pricing and it's price competitive, we've won.
We win.
So that's kind of a good place to be, and we recognize that very, very early. But they do not want to play on y'all's turf, and that's part of it. So what their strategy is that what we are all doing is it's invalid. You don't want to do that. It's not good for the country. It's all these things. There is no recognition that, oh yeah, well, we can beat them at that game. They don't want to play this game because they know they'll lose.
Yeah, there's a hospital administrator one time asked me what was I going to do when he matched the prices of our top 25 procedures. He said, I'll just match your prices. And I said, well, then we're competing on quality, aren't we? And you die. So.
Conversation over.
Yes, Kendrick?
So we've had a lot of talk about saving money, and you just brought up quality. Is the healthcare of the future even invented yet? And if not, then what are some of the things that we hope to see in terms of patient care, patient outcomes that's going to come out of the innovation of a free market movement?
Yeah, it's hard to say. I mean, who knows what, if the government will get out of the way, as almost every speaker here has indicated in the last 2 days, it's hard to know what's coming. I mean, if the government's out of the way, then the market will work to satisfy the most pressing needs, if not all of the needs of the buyers, of the consumers, of the patients. That's one thing I've been thinking about lately. Is one of the biggest problems with the industry and the economic side of it is the customer is not sovereign. I mean, the customer is a victim. And in every other industry, the customer is sovereign. I mean, if you don't satisfy the needs and wants of the buyer, then you go out of business. And I've thought about that lately. I mean, I think that really, once the free market is more accepted in this industry, then the focus will be on the buyer, on the patient, and the innovators then can imagine in an entrepreneurial way, how do we best satisfy the needs and wants of those out there, and everybody wins. So if that is allowed to happen, I don't know. I have no idea what the limit is.
Yeah, I was just going to echo that the healthcare of the future, it has not been invented yet. It'll be invented by maybe somebody in this room. Mm-hmm. But once we get to a point where people, buyers, whether it's a pool of buyers through a health share or through a self-funded employer or an individual with some sort of a benefit plan of some description, but if they're making the choices of where they buy based on open and transparent pricing and quality information, wow. I mean, I think we had a speaker that I can't. There's been a lot of speakers here. One of the speakers was saying that the innovation of healthcare has basically been stifled for 50 years, and so I think there is a tremendous amount of healthcare innovation on the business side of healthcare that is just waiting. It's like a spring waiting to explode. But what's going to have to happen is the buyer is going to have to wake up, and every single one of us is a buyer, and we're starting to see that. But once that thing comes loose, watch out. It's going to improve everybody, and there's going to be entities that are going to just be absolutely kicked in the teeth, and they're going to go out of business, which is healthy. And then there's going to be innovators that are going to come up with models that we've never dreamed of that are going to advance healthcare and lower price considerably.
Hey guys, just wanted to thank you, and being a first timer down here, remarkable what you pulled together and the breadth of the expertise we've gotten to enjoy this weekend. Subject matter experts, yes. People that make their living in the space, yes. But the professors and the CFOs and the attorneys that you brought in to add perspective, I thought was remarkable. So again, thanks for doing that. I just wondered how you roped in Steve Forbes and how you topped that next year, or did you already book him for next year?
He's an enthusiast, but it's all Dr. Smith.
Well, my wife and I had dinner with him 6 years ago. I think we decided at Oklahoma State University. We were invited by somebody there in the entrepreneurship school, which is a radically Musean bunch. We have Dr. Byland here. I love him. Anyhow, there were 3 people invited to this dinner, or 3 couples, to meet with and, chat with Steve Forbes. And I got the call from Vance Freed. And so we said, yeah, we'll go. And I remember I had just torn my hamstring and drugged my leg in because I could hardly walk. And we walked into the restaurant and sat down, and we were each supposed to spend 20 minutes with him. And he spent 20 minutes with me, and then he spent a little bit of time with the others, and then he came back around. And it was embarrassing because he was so dialed in to the idea that we had put prices online at Surgery Center of Oklahoma. It just blew his mind. And then on a Sunday night, then he reached out and we did a podcast. Some of you may have seen, he was incredibly well prepared and even brought up a story I told at that dinner in Stillwater 6 years ago about my parents' epiphany after going to Russia. And I thought, where in the world? And he remembered that from that dinner, which is unbelievable. But anyhow, we did this podcast, and in the techie sort of pregame before we went on the podcast, I asked him if he would be willing to have a conversation to consider speaking at this meeting, just kind of easing it. And he said, absolutely, what are the dates? And so we sent him the dates, and they had 2 or 3 questions, and then I swallowed hard and typed this email 6 times on the wording about, okay, how are we going to raise what I knew his honorarium was? And we're going to have to get sponsors to really cough up crazy money to bring this guy in because he's agreed to come now. And so his response was, this is the most important thing happening excuse me, in the United States. There is no honorarium. So that guy came here for nothing. I mean, I think he even paid his own expenses, right?
Yes, he did.
So that's how it happened. He's a real believer. And then after he agreed to speak, one Sunday night, it was late, I got an email, and it's Steve Forbes on a Sunday night. Hello, Dr. Smith, be in town Wednesday. Can you have lunch? And so he came to the Surgery Center of Oklahoma, and Steve Lonte and I had a photo op with him, and we had lunch and showed him around the surgery center. And he's all in, and he's telling everyone he comes into contact about what's going on, because he truly believes that, like so many that are dialed into this, that if you fix this industry, then the amount of resources that are freed up, that are not now being stolen by the industry, it's transforming for the entire country, the entire economy. He is completely dialed in and convinced of that, and he tells everyone he's fearless. He's fearless. He's associated with me and with you. I mean, come on.
No doubt.
So every year that I've come to this, it's nice to be in a geography where there is, more access to folks that are posting prices. But I'm in South Carolina. There's one big hospital that bought all the other hospitals, predominantly. The ones that are still independent are bad. You don't want to go there anyway. So
is more of a macro question. In a certificate of need state like South Carolina, which maybe that's going away next year, but my fingers aren't crossed on that. What are the first steps? So in a geography where there's basically one player, you got to tiptoe to a degree we have to have a way for employees to access that. We have to. We can't just say, no, you can't go to that hospital. You have to go, we're flying you to Oklahoma for everything. That's not practical. So in geographies that are not as far along in this movement, Alabama being another one that I work in a lot, where there's one carrier.
Right.
That's it.
Yep.
So what are the first steps in, number one, a relationship with those hospitals? What do you guys see as the most important? And the Atlas payment solution is very intriguing to me, as far as giving hospitals a way to skirt around some network arrangements. But other than that, what are the first steps that employers need to take to say, we want some skin in the game and we want a seat at the table where price is discussed, but not have the hospital say, well, go kick rocks. We're not. We have no reason to speak with you. None.
Well, you just said it. They have no reason to speak with you. So, it may not be that one employer can pull it off, but you have to give them a reason to speak with you. So they have to be concerned. My suggestion in an area like that is, if you can get enough of employers, and if you can't, you just start with one. I mean, you work with what you have. But I think what you need to do is you need to have that employer or those employers, they need to have an incentivized tier within their benefit plan. And then you need to start working with the TPA to, when it's appropriate, when there's a large gain to be had, a large savings, then you could certainly fly to Oklahoma City, but I'd also say if there was a free market friendly medical provider closer to where that big bad hospital is, something that maybe on their radar a little bit, try to divert that patient. If they've got bundled cash pricing, make the hospital aware. Hey, you're getting ready to lose this patient. It's the delta for the employer is $60,000. The patient's going to get all their expenses paid for when they make this choice, et cetera. You may not think that makes an impact, and one might not. But Keith is the one that taught me early on in this that you may not get the hospital's attention, but physicians spook easy. And so when you get 3, 4, 5 diverted, there's going to be a conversation that's going to be had somewhere in the bowels of that hospital. It may even start a conversation between maybe physicians that maybe we could start a surgery center, maybe. With CON in place, that's not going to happen. But again, you're going to have to start with what you got. And, dealing with the monopoly is not going to move the needle. It's just not. You're just going to get more of the same. Why would they deal? You've got to give them a reason. You've got to somehow regain some modicum of leverage. And the only way you're going to do that is show that hospital or that multiple hospitals that there are options available, even if they're 300 miles away.
Yeah, and you're South Carolina, which is bad, but you're not North Carolina, which is horrible. There's an employer we work with in Oklahoma that has employees in North Carolina, and they've asked Atlas us to figure out, is there someone who's reasonable we can talk to? There is no one in North Carolina. There is a surgery center in Spartanburg that is not that far, and what we found on the Atlas billing side is that if there is an actual patient, not a cold call, hey, we want to talk to you about getting more business if you'll do it this way. But if there's an actual patient that we can say, okay, we want to send you this patient for a tonsillectomy, But listen, in order to get this referral, here is how it needs to work. And you just tell us what you want to charge. And if there's an actual patient, you can really break them down. And we've seen that in Georgia and in Arizona and Washington State, where that really was the first step and got them interested. And then they realize, whoa. And to get their attention and let them know it's for real, one of the things that we do is pay them prior to the surgery. So they actually get paid ahead of time. They know this is not just some, Ethiopian or Nigerian scam call. I mean, there really are we've got our money. So yeah, they're little baby steps you can take to break it down. But Jay's right. I mean, these conversations, they may not look like they're causing anybody sleepless nights, but they do. It's very worrisome.
And, I was just having a conversation with somebody on the break, and, they had mentioned that there's, a TPA out there that is kind of, dipping their big toe into this movement, but they like to do a lot of single case agreements with the big bad hospital. And, and they're able to do that, but they're not going to change minds. They're not going to influence people. They're not going to get that hospital to all of a sudden see the light. And there's a lot of surgery center of Oklahomas out there in the country. Some of them are they're hanging on by their fingernails. And so I think it behooves, the TPAs and the consultants that are in the room is that, if you've got a bad hospital in your town, get the best deal you can get with them, even if it's not a good one. So you've got that covered. But then try to divert as many people as you can when it's appropriate to the good guy. Maybe the good guy is 3 states over. Maybe the good guy is 100 miles away, because those are the people that are doing the right thing, and we need to give them volume. And we can't sit around, we're going to, gnash our teeth and wring our hands because we can't get a good deal with this big bad hospital. The good guys don't have the time for us to sit around until hell freezes over, until a hospital grows a conscience. The good guys need volume. And that was one of the things when we started our bolt-on program 6 or 7 years ago. It was not about us making money. It was actually more about how, if I'm not able to convince a large employer in Oklahoma or Texas that they need to dump Blue Cross and Blue Shield, which is that's a bigger hurdle to get across, takes more time. I felt like I had a responsibility and a duty to this movement to figure out, how do I start getting some of those employers where I can start diverting that volume to the Surgery Center of Oklahomas of the world and help them stay alive and feed and grow? How do I create volume? And so we constructed a program that, what if you don't take all of our services and just take the services where we can divert patients and buy on behalf of that employer with the free market facilities. And I think there needs to be more of a mindset, honestly, in not just, I'm not trying to beat up on FMMA members here, but I do think there's a lot of people that will give up on hitting the single or the double because they always want to hit the home run. Sometimes we got to have incrementalism to win this battle.
We have another online question, and it says, the only thing keeping the ACA afloat right now is the government stimulus marketplace subsidies. When these expire in a couple of years, and if they don't reinstate the mandate, do you think the insurance market will collapse, or what do you think will happen?
God,
I think they'll be extended.
Go ahead. I'm sorry. I got really excited when she said insurance collapse.
I get excited about it too, but like Mr. Forbes said, once you have an entitlement out there, that they don't go away. It's going to depend on probably who's sitting in the White House and who's in Congress. But I don't see them going away.
No, I don't either. We can only hope.
Yeah. Hope.
I'm just curious what you two think COVID would have looked like if DPC was, stronger in the United States, and just like what, how it would have been different, how it would have been better, or how. I'm just curious what you think about that.
Throw that to the man in the blue jacket behind you, because that was one of his slides. Or Molly, you can answer that.
I'll let Lee have a crack at it too, but I can talk about that. So the difference between what I was doing in my community and what the hospital-based doctors was doing was I was actually bringing people into my office who were sick and seeing them. And then I take my oath seriously, so I felt that I had to take that risk. And so I was able to help a lot of people not be hospitalized. I mean, that's anecdote. It's not, I don't know that would bear out, throughout the United States. And I did get COVID. Thankfully, it didn't make me very sick, but I kind of took that as a risk. And the doctors that work for the hospital systems didn't even have that choice. So they were essentially just, telling people, not even a person doesn't even get to speak with their physician. They end up with a scheduler, and the scheduler saying, well, okay, it sounds like you have COVID symptoms, so just stay home. And when your lips turn blue, go to the ER. And I mean, that's literally what was happening. Yeah.
Yeah, so I'm going to turn your question around just a little bit and say that not how DPC could have affected COVID, but how COVID shined a bright light on the failures of the system. Because it took 3 months for Medicare to create a code and create parity for telemedicine for participating Medicare providers. And so when you're a fee-for-service practice, you're dead in the water. They essentially cut off your entire revenue stream. And so those practices, you have more than 50% of the primary care practices in the country that went nearly insolvent. So to make up for that, what Medicare essentially did was they said, we're going to pay telemedicine the same exact price as in-person visits to try to shore up some of these primary care practices. And talk about not taking something away once you give it to them. That has now been converted to permanent. So what used to be a telephone call to a primary care doctor's office that was included for free is now a telemedicine visit that's being billed $150 to Medicare in perpetuity. So you call for a blood pressure medication refill, it's $150 billed to your plan. That is going to, so for what Medicare now pays for one telemedicine visit, direct primary care can now provide 3 months of unlimited telemedicine, unlimited office visits, unlimited procedures, unlimited in-office testing. And so those numbers that I showed in my slide are about to be exploded in terms of the differences between what DPC and the power DPC can have. But on day number 1, we didn't have to wait for a billing code change. We switched to curbside medicine, telemedicine, house calls, and did absolutely everything we could. And our patients never once went without a medication refill and a doctor seeing them when they needed help.
Yeah.
That's awesome.
Again, in the Carolinas chapter, it was April 2020, so we'd been quarantined for a couple weeks by that time. So I got together some buddies, DPC doctors, Dr. Ben Aiken in Asheville of Lantern Health, Dr. Shane Purcell in Anderson of Direct Access MD, Dr. Jerome Ayai in Greenville and Spartanburg, South Carolina with Palmetto Proactive. And then who's now my doctor, Dr. Matthew Kramer of Main Street Family Medicine, but he wasn't at the time, but he is today. And I just had a nice recorded conversation with them. I posted it on my YouTube channel. We had about an hour-long talk, and they each told their stories I asked questions about. So what are your patients doing, and how are you serving them now in this pandemic? It's a nice little watch if you have about 45 minutes on your hands.
I'll give a personal testimonial about my story with COVID. My whole family has DPC and has for quite a while. Never really had any real need for it. I mean, not real need. I mean, I use them all the time. But as far as never had a pandemic when I've had a DPC subscription, But when COVID did start to happen, I reached out to my DPC, and she knows me. She knows my family. And I said, hey, what do I need to be thinking about? What do we need to be doing or not doing or whatever? And it was, kind of, it's all cool. Just, we'll stay in touch. If anything, you see, any symptoms like this or this, just give me a call. And I wanted to share this with y'all because this is something that, certainly doesn't fit on a spreadsheet anywhere. But the peace of mind that I felt, it was weird. I didn't expect it at all. But knowing that I had a doc, no offense, doc, but I mean a DPC friend, my DPC, I look at her as a friend, that she was just a phone call away. She was just a text away. And through this, somewhat scary time, I was like, when I go and talk to an employer, I don't know really how to convey that feeling to an employer that's thinking about doing DPC. But there's been a few times in me and in my family where direct primary care has resulted in almost an enlightenment about the power, as Lee was talking about, of DPC. One of them was COVID. The other one was I was in a super rush to get out of town. I know this is all stuff that you all know very well, but I just feel like sharing. I was in a rush to get out of town. I didn't feel good. I was like, God, I don't want to, be sick when I'm on the road. But I guess, hey, that's what Dayquil and NyQuil's for, right? And she said, well, I'm only going to be here for about 15 more minutes. I said, well, great. Well, I'll can I swing by? And she said, well, if you hurry. And so I swung by, walked through the front door, walked right in. She was waiting for me. Said, hey, come on back. Check me out, look me over, whatever. Yep, had, sinus infection like I always do, almost like clockwork. And as I was turned around, left, there was my meds were sitting there in a little white paper baggie on the counter. I picked them up and I left, and I almost had to catch myself that, did I just shoplift? I know all about DPC. We've been doing it for years, but it was just one of those things that hit me. Okay, I was just in and out, got an examination and a prescription, and I'll bet you I wasn't in that office 5 minutes. And anyway, must be tired. But it's cool stuff.
It's cool.
We got an online question here. What is new or on the horizon for this movement?
I think it's quiet in it, but it's happening. We're seeing the breakdown of the big hospital systems because of this movement. There are folks that are breaking ranks that are very, very scared of losing business. Kylie Mays and I are really disrupting things with this little tool we have called Atlas Billing that's removed any hospital's excuse that says we can't do that. Atlas will do it for them. So if anybody ever says at a hospital, we can't do that, well, they can. And there will be many, many competitors to Atlas Billing, I think, because it's a tool that removes the impossibility of hospital claims they have on curating or implementing bundle payments. So there are hospital systems that are putting their toe in the water that don't really want people to know about it. They primarily don't want the carriers to know about it. But as I've said, if they think they're about to lose a patient, they know that if they do lose that patient, it's potentially a real snowball, and it's just gonna get real bad for them. So I'm really optimistic. I maybe more so than ever, and I typically am, even if I'm wrong, because I think we're seeing it in Oklahoma City. We're seeing it outside of Oklahoma City, where that call to a hospital not just about a single case agreement, but it's very disarming. You ask a CFO of a hospital, how much do you want for this procedure? Don't worry about anesthesia. Those guys are out of control. I'll talk to them. But how much do you want for this procedure? The patient's coming in from Florida. It's not a patient you might see otherwise, or worse, this patient lives there, but they're getting ready to fly to Oklahoma City. Let us help you, minimize the inconvenience to this patient so that they can stay home. And that's working. And I would say 2 years ago, that was not meeting with the same success that we're meeting with now. So I think that it's not crazy to say that even the biggest hospital systems know and recognize the inevitability of this movement. I mean, they're fining hospitals for not posting their prices. I mean, who would have thought? I mean, it was crazy to post prices, and now you're penalized if you don't. So I think we're really near a tipping point. The last element of which needs to be added is a piling on by the buyers, and it's the self-funded employers. And then the hospitals are going to have to respond to a buyer that says, I want to know how much it's going to be, and I need you to tell me up front, or we're going somewhere else, and it'll happen. And I think we're on the brink of that. That's what I think is on the horizon.
Yeah, I would agree. I'll tell you, it's getting a lot easier to get direct contracts. It's a lot easier to negotiate with, whether it's a rural hospital, a large hospital system, or an independent ASC. It's very rare that we make a phone call or an outreach, or we get a phone call where there's not an awareness of what cash bundles are, that there's an awareness of employers wanting to do a deal and bypass the PPO networks. 3 years ago, it was, you just felt like you were, you were some just goofball talking to these people, because they looked at you, and or you could hear their voice over the phone, that they just thought you were some sort of a nut. Might take you 2 years to get to the point where they're actually willing to talk real with you. Now, it's a lot more simple. But I would echo what Dr. Smith said, especially for the employers in the room. And if you're in this room and you're an employer, you do already get it. But I will say, for others that are in your peer group, to the physician out there I think you're a consultant, sir, right? What makes it the most difficult to break through and get a hospital to deal is when the employer is reluctant to take patients or allow patients to be redirected away from their big bad hospital. It's the darndest thing. And for Pear, I know you probably just shaking your head, because this is just basic economics. This is basic supply and demand and competition. If you want to bring somebody to the table, they have to pay a price for not coming to the table. And employers are very reluctant in some communities I said in my opening remarks, we don't want to hurt the hospital. Well, you've just come to me and told me the hospital is hurting you. But they're not going to take the knife out of your back unless they understand that there's a price to pay for that. And so that's the thing that I would hope that we continue to see momentum on the employer side. And I think just by the fact that there are more employers here in this room wanting to hear this message, that we've talked about this over and over again, Keith and I have, if the employers and the buyers, because the employers I know some of the docs out there, maybe don't necessarily agree that employers will drive this, but that's where the numbers are. When the employers wake up and start demanding this, the dominoes will just start falling. They really will. Well, thank you all very much for all the engaging conversation.